Imagine, if you will, that you were sick.
Right.
Like not just a minor cold, but you are really, really sick.
The scary kind of sick.
Exactly. You are sitting in this sterile clinic waiting room wearing one of those paper-thin gowns that, never quite closes in the back.
Oh, yeah. Those are the worst.
They really are. And you just feel entirely vulnerable in that moment.
Mm-hmm.
The air smells like antiseptic and old magazines.
Yeah.
And in that moment of profound vulnerability, you make a few fundamental assumptions.
You have to, right? Just to get through it.
Right. You assume the person who's about to walk through that door and treat you has undergone years of rigorous, grueling medical training.
Which is a very fair assumption.
I mean, you assume the institution standing behind them, like the hospital, the regulatory board, the whole healthcare apparatus, prioritizes your life above absolutely everything else.
Yes, that is basically the bedrock of the social contract we have with medicine.
What if that system is, itself fundamentally sick?
That is the big question.
Yeah. Like, what actually happens behind closed doors when the colossal business of healthcare overrides the ancient ethics of healing?
Well, it is a terrifying question to confront, because when you actually look at the evidence, the internal investigations, the whistleblower accounts, that social contract is fraying at the seams.
It really is.
We were looking at a landscape where intense financial pressures, widespread institutional cover-ups, and a deliberate blurring of professional boundaries are causing a full-blown crisis.
A crisis in medical ethics.
Exactly.
And we are not just talking about abstract philosophical dilemmas today. We are pulling back the curtain on an incredibly dense, frankly, shocking stack of materials for today's deep dive.
Yeah, the source pile for this one is massive.
It is. We have got medical ethics manuals from the World Medical Association. We have investigative reports on pharmaceutical regulatory capture.
Which includes the horrifying details of the Vioxx scandal, by the way.
Right, the Vioxx scandal.
Yeah.
And we are digging into internal documents regarding the UK's National Health Service and the General Medical Council.
And perhaps most importantly, we have these gripping, first-hand accounts from doctors who tried to blow the whistle.
Doctors who exposed incredibly dangerous practices and paid a terrible price for it.
So our mission today is to connect those dots.
Yeah, let's lay it out.
We need to show how these systemic ethical failures at the administrative level are directly fueling things like the rise of deadly superbugs.
Wow.
Yeah, they are compromising patient safety and inflicting entirely avoidable pain and suffering on patients all over the world.
The best analogy I can think of for what we are about to explore is, well, it's like a massive automated assembly line.
Okay, I like that visual.
Right. So the workers on the floor, the doctors, the nurses, the frontline staff, they can clearly see that the product coming down the line is flawed.
They see the defects firsthand.
Exactly. They know the machine is calibrated wrong. But the managers up in the glass offices refuse to reach out and hit the big red stop button.
Because stopping the belt slows down production.
And slowing down production hurts the bottom line.
Right.
So the flawed products just keep rolling out the door.
That is a perfect way to frame it. And to understand how we got to this assembly line mentality, we really need to start at the foundation.
Let's do it. Where do we begin?
For centuries, the absolute core of medicine has been the sanctity of the doctor-patient relationship.
Right, the traditional healer and patient dynamic.
Exactly. It is a relationship built on trust, empathy, and highly individualized care, but that relationship is being systematically dismantled.
How so?
Well, there is a fascinating analysis in our stack from a clinical endocrinologist, Dr. Dolinar. He details how doctors are essentially being forced into a system of top-down cookbook medicine.
Cookbook medicine. Okay, hold on, though. Let me play devil's advocate for a second.
Sure, go for it.
When you say cookbook medicine, you mean standard operating procedures,
Yeah,
right?
basically, yes.
In aviation or engineering, we love standard operating procedures. We want the pilot following a strict checklist so the plane doesn't crash.
Right.
So why is it inherently bad to have rigid guidelines and algorithms in medicine? Doesn't that prevent rogue doctors from just guessing and making mistakes?
Well, that is exactly the logic administrators use to implement these systems. And in a purely mechanical system, you are absolutely right.
Okay.
But human biology is not mechanical. A Boeing 737 is identical to every other Boeing 737. but human biology is infinitely variable.
That makes sense. We are not airplanes.
Right. What Dr. Dolinar is highlighting is the erosion of professional autonomy in the face of that biological variance.
So the doctor can't adjust for the individual.
Exactly. In a traditional setting, a doctor uses their extensive training, their clinical experience, and their deep observation of the specific human being sitting in front of them.
To formulate a nuanced treatment plan.
Yes. But top-down rules, things like rigid Medicare guidelines, insurance mandates, and electronic health records that literally force you to click through drop-down menus, well, they undercut that integrity.
So it replaces personalized nuanced care with a generalized flowchart. Like if symptom A, then prescribe drug B.
Precisely. And this kind of rigid standardization actually retards medical innovation.
Wow.
It introduces this bizarre gaming of the system where doctors spend more mental energy figuring out how to code a diagnosis just right to secure reimbursement.
Instead of focusing on the actual patient.
Yeah, rather than focusing purely on the physiological reality of the patient. It totally weakens that traditional bond.
This leads directly into a concept from the sources that completely reframed how I view the medical profession right now.
Oh, the Harvard report.
Yes, the Harvard School of Public Health report. It focuses on something called moral injury.
That is such a powerful term.
It really is. Now, we hear the term burnout all the time. Doctors are burned out, teachers are burned out.
Right, everyone is burned out.
But this report draws a massive critical distinction between burnout and moral injury.
Because burnout implies a failure of the individual's resilience, it suggests the doctor just couldn't handle the stress.
Like they didn't do enough yoga or practice enough mindfulness on their days off.
Exactly. It places the blame entirely on the worker. But moral injury is different.
Where did that term even come from?
It was actually originally coined by military psychiatrists. They used it to describe the trauma of soldiers who were forced to act against their own moral codes in war.
Wow. So it shifts the focus entirely to the system. But how does that map onto a doctor in a modern clinic?
Well, the report defines moral injury in medicine as the profound, soul-crushing demoralization that physicians feel when they are placed in conditions completely beyond their control.
Right.
Think about navigating patient poverty or battling a lack of insurance authorization for a life-saving drug.
Or being forced into unreasonably short 15-minute appointment time.
Exactly, and drowning in massive administrative burdens. It is the trauma of knowing exactly what your patient needs to heal, but being structurally blocked by the system from providing it.
It is the trauma of being complicit in a system that you know is actively failing the person you took an oath to protect.
Yes, and it is not just the administrators causing this pressure. The environment has become incredibly hostile from multiple directions.
Oh, absolutely. The fee-for-service models inherently create a conflict of interest, right?
They do. The system rewards volume over value.
The more procedures you do, the more you get paid, regardless of whether it is the most ethical, conservative path.
And then there is the tension with the patients themselves.
Oh, man, yeah. The sources really get into this.
Patients today are heavily conditioned by a consumerist culture. They see pharmaceutical ads on television, they read WebMD, and they come into the clinic demanding very specific treatments.
Like they want a specific brand name pill, or they demand antibiotics for what is clearly just a viral cold.
Right. And if the doctor, using their years of training and ethical judgment, denies that request, the patient often becomes abusive.
So the doctor is caught in a vice.
Exactly. If they prescribe the unnecessary antibiotic, they violate their medical ethics, they potentially harm the patient's microbiome, and contribute to global antibiotic resistance.
But if they refuse, the patient complains to the administration.
Yes. The doctor gets a bad review on a patient portal, and the hospital managers pull the doctor into a meeting to reprimand them for poor customer satisfaction scores.
It creates an impossible ethical paradox.
Well,
So, if the system is constantly forcing doctors to rush, and patients are actively demanding quick fixes and getting hostile when they don't get them,
yeah.
isn't the fundamental definition of a good doctor changing? It feels like the administration is trying to transform them from a healer into a glorified customer service rep.
That is a brilliant observation, and it connects deeply to a philosophical concept discussed in the texts regarding virtue ethics in primary care.
Virtue ethics.
Specifically the concept of reflectiveness. In Aristotelian virtue ethics, true healing requires the physician to possess eudaimonia.
Okay, that sounds intense. What is that?
It is a state of flourishing, well-being, and profound reflectiveness. This state is what allows them to extend deep empathy to the patient.
Let me try to ground that. Is it kind of like the oxygen mask analogy on an airplane?
Oh, I like that. Go on.
Like, you have to secure your own mask before helping others. You
Mhm.
can't extend true well-being and empathy to a patient if you are completely suffocating yourself.
That is the perfect way to visualize it. Modern doctors reside within a system that literally suffocates virtue.
Man.
They cannot access the empathy needed for patient flourishing because the systemic structure just doesn't allow it.
Because of the 15-minute slots and the endless clicking on computers.
Exactly. The constant threat of litigation or administrative punishment does not allow the time, the space, or the emotional bandwidth for reflectiveness.
So the system essentially mandates unvirtuous practice by starving the doctor of the resources needed to be a true healer.
Yes. So the doctors are experiencing moral injury, they are being suffocated by the system, and as a result, many are just throwing their hands up and leaving the profession entirely.
They are retiring early, shifting to non-clinical roles, or just walking away. So if the highly trained doctors are leaving, how on earth are these massive healthcare systems coping with the shortage?
Well, who is actually treating the patients?
Right.
They are coping by playing the substitution game.
The substitution game. That sounds ominous.
They are actively replacing highly trained doctors with cheaper, significantly less trained alternatives.
Okay.
On a spreadsheet to a hospital administrator, this looks like brilliant efficiency. But the clinical and ethical implications are catastrophic.
Let's look at the raw math here, specifically focusing on the UK's National Health Service as a primary example of this global trend.
Good idea.
It costs roughly £230,000 to train a junior doctor in the UK.
That is a massive investment of time and state resources.
It really is.
Mm.
So to cut costs, the NHS long-term workforce plan is pushing for a massive structural shift.
Right.
They are aiming for huge increases in the employment of physician associates, or PAs, and advanced medical practitioners, AMPs. The plan explicitly aims to have at least 10,000 PAs integrated into the system by 2031 or 2032.
And the financial incentive for the institution is glaringly obvious here.
Oh,
A PA or an AMP commands a significantly lower salary than a fully qualified general practitioner or a specialist doctor.
you are substituting expensive, highly specialized labor with cheaper, generalized labor.
Exactly.
But wait, doesn't the sheer volume of patients make this kind of triage necessary? I mean, if I just have a minor earache, maybe I don't need a doctor with 10 years of medical school and residency.
Right. Maybe a physician associate is perfectly fine for that.
Yeah, that is the exact argument institutions make.
The justification often given, and there was a prominent BBC News report about this years ago regarding nurses and pharmacists, is that granting these roles greater powers to prescribe drugs gives patients quicker access to medicine.
It sounds fantastic on a political brochure. Like,
Well-
we're cutting wait times, we're expanding access.
Right, but what happens when your minor earache is actually the early presentation of a complex neurological issue?
Oh.
Yeah,
Yeah.
and that is where the ethical concern becomes profound.
So it isn't just about doctors being territorial over their jobs.
Not at all. It is about protecting professional boundaries that exist entirely for patient safety.
The investigations categorize this phenomenon as when the nurse wants to be called doctor.
Yes. Walk-in clinics and out-of-hours services are increasingly being entirely managed by nursing staff or PAs without direct, on-site, contemporaneous doctor supervision.
It effectively blurs the most crucial boundary in medicine, which is the boundary of diagnostic capability.
It does.
It's like hiring an electrician to do a structural engineer's job simply because their hourly rate is lower.
That is a terrifying analogy.
I mean, the electrician is highly skilled at what they do. They are essential. And the lights might turn on just fine on day one,
Sure.
but because the electrician does not understand the complex load-bearing physics of the building, they might drill a hole through a vital support beam to run a wire.
And the house looks fine, but the structural integrity is compromised.
Exactly. Eventually, the whole house collapses on top of you. It's a fundamental mismatch of training to task.
And these aren't abstract worries. We have very specific, horrifying case histories submitted to the regulatory boards by whistleblowing doctors.
So let's get into those.
Okay, let's look at one documented reality from a nurse-led walk-in clinic.
Okay.
A patient presented with a rash that wasn't getting better. The nurse, relying entirely on a pre-printed assessment protocol, the cookbook medicine we discussed,
Right.
well, she misdiagnosed the condition as simple dry skin or eczema.
Because the flowchart basically said If rash and itchy, give steroid.
Exactly. So the nurse prescribes topical steroids. But
Wow.
because the initial diagnosis was fundamentally wrong, the treatment was disastrous.
Why? What did the steroids do?
Steroids suppress the local immune response. They reduce inflammation, which makes the skin look a little less red temporarily, but they turn off the body's natural defense mechanism.
Oh no. And what was the rash actually caused by?
What was actually a fungal infection, and in some cases scabies, was allowed to multiply unchecked because the immune system was chemically told to stand down by the steroid.
That is horrifying.
Eventually, this led to severe bacterial infections, including multi-resistant Staphylococcus aureus, or MRSA, spreading like wildfire.
Just because of a misdiagnosis at the very start.
Diagnosing complex dermatological presentations is hard enough for seasoned physicians. Expecting a nurse relying on an algorithm to catch the nuance of a rare fungal infection masquerading as eczema is a recipe for disaster.
And this tension over the value of rigorous medical training has reached boiling points.
It really has.
We have to talk about the 2023 junior doctor strikes in the UK. And I want to make sure we present this objectively, exactly as it played out.
Right, without taking a political side, because the ethical dilemma here is profound.
A situation is incredibly complex. On one hand, you had junior doctors going on strike for pay restoration.
They argued that their pay had degraded significantly since 2008 when adjusted for inflation.
And that their stressful, overworked conditions were completely unsustainable.
Now, from an objective standpoint, the short-term consequences of these strikes were severe. Around 200,000 appointments and procedures were canceled over just a few days.
200,000. The immediate ethical implication there is undeniable. Patient care was compromised in the short term.
Wait lists grew longer.
And immense stress was placed on the remaining staff and the senior consultants who had to cover the emergency wards.
But the counter-argument from the striking doctors presents a different, deeply terrifying ethical scenario.
What's their argument?
They argue that if they did not strike, the long-term ethical implications would be far worse.
How so?
The logic is that without pay, restoration, and sustainable conditions, the moral injury will continue to compound. Doctors will continue to burn out, leave the profession entirely, or emigrate to countries with better healthcare systems.
Which leads to a permanent systemic collapse of the medical workforce.
Exactly. You would have complex specialist positions completely unfilled in the future.
So you have two deeply conflicting ethical realities. The immediate, tangible harm of canceled appointments today versus the potential long-term systemic collapse of the entire profession tomorrow.
It highlights just how much strain the entire ecosystem is under. But we need to circle back to those misdiagnoses in the nurse-led clinics.
Right.
Because the consequences of handing out the wrong medication don't just stop at the individual patient suffering from a misdiagnosed rash.
No, they don't.
These specific types of diagnostic errors, particularly the overprescription of drugs, are actively fueling a global existential crisis.
You were talking about the threat of antimicrobial resistance, AMR.
Yes. The warnings here in the documents are dire. The threat of AMR has the potential to bring the entire medical profession to its knees.
Let's look at the data highlighted in the whistleblower accounts.
An estimated 37,000 to 39,000 people develop septicemia, a life-threatening bloodstream infection, and die every single year due to errors in diagnosis committed by frontline staff in primary care settings.
39,000 people. That is a staggering loss of life.
And the tragic, almost sick irony is why this is happening.
Right. In this environment where patient satisfaction scores are tied to hospital funding.
Or where there is this underlying institutional desire to prove that the cheaper nurse-led model is just as effective as the doctor-led model.
There's a reckless urge to prescribe antibiotics.
It is the path of least resistance. A patient comes into a walk-in clinic with a viral upper respiratory tract infection, a URTI, or a viral lower respiratory issue.
Okay.
To accurately diagnose that it's viral and not bacterial takes time. To sit down with the patient, explain the biology of why antibiotics won't work on a virus, and deal with the patient's inevitable frustration.
Yeah, that takes a tremendous amount of time and emotional energy the frontline worker doesn't have.
So to keep the assembly line moving, they just write the script for the antibiotic.
But by improperly diagnosing URTIs and urinary tract infections and just blindly throwing antibiotics at them, primary care providers have effectively acted as a training ground for bacteria.
They have. Every time you expose a bacterial population to an antibiotic when it isn't absolutely necessary, you kill off the weak bacteria.
But the strong mutated ones survive and multiply.
Over years of doing this practice has helped create an army of what researchers identify as 18 massive microorganisms that are now highly resistant to our entire arsenal of drugs.
18 resistant superbugs. This threatens everything.
It really does.
If we lose the efficacy of antibiotics, routine surgeries become fatal. A simple scrape on the knee could kill you. Childbirth becomes massively dangerous again. We literally return to the dark ages of medicine.
And here is where the story shifts from tragic systemic failure to active institutional malice.
That's a strong word.
It is. It's one thing if this crisis is just a byproduct of a complex, overworked system, but there is a specific instance detailed where a concrete solution was offered and it was deliberately ignored.
Yes, this part is infuriating. A doctor, seeing this exact crisis unfold in the NHS, seeing the misdiagnoses, the inappropriate prescribing, the rise of superbugs, actually invented a tool to fix it.
He created something called Maya.
What was Maya exactly?
Well, Maya was a brilliantly simple, color-coded symptom system. It was designed specifically to help nurses and frontline staff differentiate between a patient who is definitively well and a patient who is potentially unwell.
So it was a guide.
Yes. The whole point was to provide a rigorous, objective guide on when it was safe for a non-doctor to manage a patient themselves and when they ethically and clinically needed to refer that patient to a fully trained doctor.
It was a safety net. It was designed to protect patients from the structural engineer versus electrician problem we talked about earlier.
Exactly. And he didn't just patent this and try to sell it for millions.
No. He sent this tool, which actually took the form of an easily accessible color-coded fridge magnet, directly to the UK's Secretary of State for Health and the highest levels of the NHS.
He laid out the problem, provided the hard evidence of the misdiagnoses and the spreading superbugs, and offered a free practical solution to stop the bleeding.
And they ignored it. But why? Seriously, if a doctor hands the government a tool that prevents misdiagnosis, stops the spread of superbugs, and literally saves tens of thousands of lives, why on earth would they ignore it?
Why throw it in a drawer?
Yeah.
Because accepting the tool would require acknowledging the flaw in the system. If you look at the institutional behavior, it is entirely driven by ego and the absolute need for control.
So when this doctor challenged the Secretary of State and the NHS over these practices, when he pointed out that their economic model of replacing doctors with nurses was actively causing harm, the institutions closed ranks.
Because adopting the MAS tool would have been a tacit public admission that their cheaper, nurse-led walk-in clinics were, in fact, unsafe without strict parameters.
Exactly. So instead of adopting a simple safety tool that protected the patient, they defended the institutional model.
They protected the system, the policy, and their own political reputations, rather than the vulnerable human beings they are mandated to care for.
It's the assembly line managers refusing to stop the belt, even when someone walks up and hands them the exact wrench needed to fix the broken machine.
That is exactly what it is.
They'd rather keep producing broken parts than admit to the shareholders there's a problem on the floor.
But wait, where's the oversight? If a hospital is actively ignoring safety tools, covering up misdiagnoses, and fueling a superbug crisis, why doesn't the regulatory board step in?
Isn't there a watchdog?
That brings us to one of the most terrifying concepts we have to cover today. We assume that massive regulatory bodies are the ultimate watchdogs.
Right.
But what happens when the watchdog is actually on the payroll of the burglar? This is a phenomenon known as regulatory capture.
Regulatory capture. Let's break that down.
It is a well-documented concept from political science. It describes a situation where a regulatory agency, which was created to act purely in the public interest, instead advances the commercial or political concerns of the special interest groups that dominate the industry it is charged with regulating.
And the documents provide a meticulous blueprint for how this works, using one of the most devastating pharmacological disasters in history as the prime example.
The Vioxx scandal.
Yes. Let's look at the numbers on Vioxx because they're chilling.
Go ahead.
Vioxx was a painkiller, a KOX2 inhibitor, heavily marketed for arthritis by the pharmaceutical giant Merck. It was supposed to be a miracle drug that relieved pain without causing stomach ulcers.
But before it was finally withdrawn from the market in 2004, it caused an estimated 88,000 to 140,000 heart attacks in the United States alone.
And the data suggests 30 to 40% of those heart attacks were fatal.
We are talking about tens of thousands of deaths from a drug that was prescribed to treat joint pain.
So how did a drug that lethal make it to market and stay on the market for years?
The White Rose research paper breaks down exactly how the UK regulator at the time, the Medicines Control Agency, or MCA, fell victim to regulatory capture.
They identify 3 specific mechanisms that paralyze a regulator. Let's go through them.
The first mechanism is perhaps the most well-known, but it's crucial to understand how deeply it corrupts oversight. It's called the revolving door.
The revolving door.
This is the constant, lucrative swapping of jobs between the regulatory agency and the pharmaceutical executives.
Right. Imagine you are a mid-level regulator at the agency. You are making a government salary,
Okay.
and you are assigned to review a multi-billion-dollar drug application from a massive pharmaceutical company.
And you know that in 3 years, when you leave the agency, that exact same pharmaceutical company could offer you a vice president position making 5 times your current salary.
Precisely. It inherently compromises objective oversight because a regulator is always conscious of their future employment prospects.
You aren't going to play hardball and demand more rigorous safety trials from the company that is essentially your future employer. It is an incestuous relationship.
It really is. The second mechanism they highlight is incredibly devious. It's called information overload.
How does that work?
Well, the pharmaceutical companies have vast, almost limitless resources. When they submit a drug for approval or review, they don't just send a summary document.
They flood the regulator with mountains of data.
We are talking about hundreds of thousands of pages of clinical trial results, raw patient data, and complex statistical analyses.
They weaponize information.
Exactly. They know that the regulatory agency is often underfunded and understaffed. The regulators simply do not have the manpower or the hours in the day to comb through every single page of raw data.
Effective oversight becomes physically impossible.
So what happens? The overworked regulator ends up relying on the pharmaceutical company's own executive summaries of that data.
Which are, of course, spun in the best possible light. They bury the cardiac risks on page 4,000 and highlight the arthritis relief on page 1.
And the third mechanism of capture is the most insidious because it happens unconsciously. Shared cultural frameworks.
What does that mean in practice?
Over time, through constant interaction, attending the exact same medical conferences, and the revolving door we just talked about, the regulators and the industry executives begin to adopt the exact same worldview.
So the regulator stops thinking like a skeptical public health advocate.
And starts thinking like a pharmaceutical executive. They start prioritizing speed to market, profit margins, and industry growth over a hyper-cautious approach to patient safety.
The culture of the regulator is completely captured.
And this capture isn't just limited to drug regulators.
No, it isn't.
The whistleblowing documents pivot back to the medical boards themselves, specifically the General Medical Council in the UK and the various royal colleges.
These are the institutions that grant and revoke medical licenses.
The sources argue, with blistering intensity, that these institutions have abandoned their role as protectors of the public and have instead acted as commercial entities protecting the state apparatus.
Look at how the GMC operates its disciplinary panels.
Yeah, this part is wild.
When a doctor is accused of an error, or when a doctor blows the whistle and the hospital retaliates by filing a complaint against them, the GMC calls in experts to offer an opinion on the doctor's fitness to practice.
But the investigations allege that the GMC frequently uses doctors who are entirely unqualified to judge the specific case.
They use retired doctors who haven't practiced medicine in decades, or doctors from entirely different specialties.
Imagine asking a community dentist or a general family practitioner to pass judgment on the complex, split-second clinical decisions made by a neurosurgeon in a high-pressure trauma environment.
It's absurd. The investigations explicitly state that it looks as if the majority of doctors offering expert opinion don't even understand the clinical context the accused doctor was operating in.
It functions as a kangaroo court.
The whistleblower argues that this is fundamentally unethical, it brings shame to the profession, and it is designed to conceal the truth.
Because by supporting the replacement of doctors with nurses, and by using these kangaroo courts to punish anyone who speaks out against it, these institutions are covering up massive liabilities.
We are talking about billions of pounds spent on compensation payouts for entirely avoidable deaths and injuries.
They are protecting the system's reputation and its finances over the lives of patients.
Which brings us to the final and perhaps most tragic line of defense in medicine.
Who is that?
When the system is captured, when the assembly line is churning out defective parts and the managers are actively covering it up, who is left to protect the patient?
The whistleblower. The individual doctor who refuses to look the other way.
Exactly. But as we are about to see, the system has evolved a brutal, highly effective immune response designed to completely destroy them.
Let's look at the ethical mandate first. The World Medical Association International Code of Medical Ethics is very clear on this.
What does it say?
It states that a physician must report to the appropriate authorities those colleagues who practice unethically or incompetently. It is a fundamental professional duty to protect the public.
But in a rather ominous caveat, the manual also warns that reporting should be a last resort.
Why?
Because, as the manual explicitly acknowledges, the consequences of reporting are incredibly detrimental to the whistleblower.
It leads to almost certain hostility and ostracization.
The ethics manual essentially says you are morally obligated to jump on this grenade, but be warned, it will destroy you.
And the realities detailed in the investigations prove that warning to be a massive understatement. The system doesn't just ostracize truth tellers. It seeks to annihilate them professionally and personally.
We see a whole arsenal of tactics used to silence dissent.
For example, in the paper discussing the censorship of doctors during the COVID-19 pandemic, we see reports of scientifically valid, peer-reviewed papers being suddenly retracted by publishers just days before crucial FDA meetings, simply because the findings challenge the institutional narrative or threatened pharmaceutical interests. The only legal way a publisher is supposed to pull a paper is if it's scientifically invalid. But editors admitted the papers were structurally sound.
It was pure, unadulterated suppression.
The tactics get even more aggressive when applied to individuals. The documents describe targeted defamation campaigns, sudden dismissals from long-held jobs, and aggressive attempts to revoke medical licenses.
There is one detail that is straight out of a dystopian novel.
Oh yeah, tell them about the office inspection.
A doctor reported that the medical board showed up unexpectedly at his private home to conduct a medical office inspection without a warrant, simply because his home address was listed as his business office in their administrative records.
It is pure state-sanctioned intimidation. It's the system sending a message, we can get to you anywhere.
And this isn't a new phenomenon. It's a deeply ingrained pattern.
Right. Look at the infamous Bristol Royal Infirmary case from the 1990s.
Dr. Stephen Bolson.
Yes, a consultant anesthetist who spent 5 agonizing years trying to blow the whistle on horrific, unsatisfactory standards in pediatric heart surgery.
Babies were dying at incredibly high rates because the surgeons were inexperienced and the system refused to admit it.
Yes, and Dr. Bolson collected the data and exposed it.
He was eventually vindicated, and his actions led to a massive public inquiry in the Public Interest Disclosure Act of 1998 in the UK, which was supposed to protect whistleblowers.
But what was his personal reward for saving future lives?
He was so completely ostracized, so deeply despised by the British medical establishment for shopping his colleagues, that he was effectively blacklisted.
He was forced to flee the country and rebuild his entire career in Australia.
And that leads us to the ultimate price paid by the doctor at the center of many of our primary documents today.
Dr. Srivalsa.
This is a doctor who saw the exact system failure we've been discussing. He saw the quackery, as he called it, of replacing highly trained doctors with nurses who were relying on pre-printed sheets and making devastating diagnostic errors.
He didn't just complain in the break room. He tried to fix it. He is the one who invented the main tool we talked about earlier.
He made protected disclosures to his employer and to the General Medical Council, fully believing they would act in the interest of public safety.
He believed the system worked.
But instead of investigating the systemic failures he exposed, the institutions turned the full weight of their power against him.
The GMC and the health authorities retaliated with punitive sanctions designed specifically to discredit his reputation.
They subjected him to a humiliating 4-year-long disciplinary inquiry based on unsubstantiated complaints, many of which he claims were orchestrated by the very staff he was raising concerns about.
They used the regulatory capture we discussed to turn him into the problem. They dragged him through the mud so that the public would focus on this troublesome doctor rather than the dead and injured patients in the nurse-led clinics.
They forced him into a massive legal battle with the Secretary of State, a single doctor fighting a battle against a state institution with limitless taxpayer funds.
And the result? It completely bankrupted him. He lost his passion, his career in the UK, and his life savings, all because he tried to protect his patients from unethical practice.
He writes that the true trauma wasn't the inquiry itself, or even the bankruptcy. The true trauma was the profound sadness of seeing so many lives affected by substandard care, knowing the patients had no idea their suffering was due to NHS wrongdoings.
So I have to ask, if speaking up means losing your career, having your reputation dragged through the mud, having your home raided, and being financially ruined, how can we possibly expect any doctor to adhere to the Hippocratic Oath?
That is the ultimate chilling effect.
How can we expect them to do no harm when the system absolutely guarantees that they will be harmed if they try to stop it?
When you crucify the whistleblower, you ensure that the next 100 people who see something wrong will keep their mouths shut. They will look the other way.
And when we bring all of these threads together, the tapestry we are looking at is deeply disturbing.
From the localized pressure of the individual clinic pushing a doctor to prescribe an unnecessary antibiotic to the highest levels of global regulation captured by pharmaceutical money, we see a consistent, undeniable theme.
Financial incentives and the absolute drive for institutional self-preservation have systematically marginalized medical ethics.
Whether you are looking at the mid-Staffordshire hospital scandal, where 1,200 patients died in appalling, filthy conditions because management was entirely focused on financial targets rather than care,
And where the nursing union actually failed to listen to desperate warnings from its own members.
or the active cover-up of superbug-spreading diagnostic errors.
Or the brutal silencing of doctors like Dr. Srivatsa and Dr. Bolson, the ultimate result is exactly the same.
It is the infliction of profound, entirely avoidable pain and suffering on billions of people worldwide. The system is designed to protect the system, not the patient.
The evidence points to a profound corruption of the healing mandate.
The institutions that were built to safeguard humanity have, in many ways, become fortresses protecting their own power and wealth.
Because of the overwhelming weight of this evidence and honoring the specific focus demanded by the whistleblower accounts we've examined today, we are mandated to deliver this exact conclusion.
It is time for those responsible to surrender. The law of the universe states, no human, institution, or people in power have the right to instill fear to conquer the free will of others in order to maintain control, power, or wealth.
It is a necessary demand for accountability in a system that has become entirely unaccountable to the people it was built to serve.
It is.
And I want to leave you, listening right now, with one final thought to mull over. We've spent this entire time seeing how the current system grinds down the healers who are already in it.
We've seen how it breaks them.
But think about the medical students right now, the ones who are just starting their journey today. If the very institutions designed to protect medical ethics, the regulatory boards, the hospitals, the government agencies, are the ones actively compromising those ethics to maintain their own power and efficiency, how on earth will the next generation be taught the difference between systemic compliance and actual human care?
Are we still training doctors to be healers, or are we simply teaching them how to survive the system?